Good afternoon. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. We have a number of members participating remotely today. Before we proceed, I'd like to go over some items for those members who are participating remotely. First, if you're experiencing any connectivity issues, please make sure you or your staff contact our designated technical support so these issues can be resolved immediately. And members who are participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee and subcommittee policy that members participating remotely will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all the members on the committee so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you'll need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. If you wish to be recognized, please raise your hand using the WebEx raise hand function, unmute your microphone, and ask to be recognized. In order to ensure everything members say is captured on the live stream of this hearing, I ask all members to please pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. And please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of committee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? All right. Well, with that, I will now recognize myself for an opening statement. As chair of the Technology Modernization Subcommittee, I'm a proponent of using modern tools to conduct business of the subcommittee. Through our oversight, we have urged the VA to modernize its operations through technology. In fact, we have come here today to discuss one particular area of VA's operation, which is telehealth, where VA is at the forefront of using modern technology to deliver care to veterans. I have been complimentary to the VA's response to the coronavirus pandemic, being at the forefront of prevention, contact tracing, and treatment. So I'm perplexed at the VA's insistence that we conduct this hearing in person. Perhaps it's because, as was discussed at last week's full committee hearing, the White House has demanded that we buck public health experts' advice and gather in this room to do something that could easily have been done with existing technology. Some VA witnesses have been able to appear remotely today, as well as our second panel of witnesses, and I applaud their prudence and thoughtfulness towards health and well-being of others. I thought this topic was very important and a timely one, so I did not want to have a further delay. However, I want to express my extreme frustration that the VA did not deliver its testimony for today's hearing at the requested deadline, and it arrived very late, which hindered our ability to prepare. It's unreasonable and quite honestly a disservice to veterans that VA makes demands that we travel here for a hearing and then not meet its own responsibilities. VA has long been a leader in telehealth, but the arrival of COVID-19 presented a new challenge to VA's ability to deliver quality care remotely. Today, we will discuss how VA has used technology to soften the impact of the pandemic on veterans, specifically by rapidly scaling up its infrastructure and mobilizing its providers to be able to deliver care through telehealth. Congress also saw the need and provided resources. to rapidly scale technology and provide flexibility in care delivery. These changes enabled the VA to continue its vital mission even while the parameters of healthcare have dramatically changed. While there have been successes in this scaling up, many questions still remain about the future of telehealth at the VA. Also, we cannot assume that scaling up equals access. As we will hear most acutely from our second panel today, access to care remains an issue for many veterans, whether it is because of geography, lack of resources, or infrastructure, or because of systematic disadvantages. The VA quickly worked to limit potential exposure to the virus by paring down its in-person services to essential care and limiting access to facilities. This action no doubt slowed down the spread of COVID-19 and may have saved thousands of veterans' lives. Yet as necessary as those restrictions are, they cause millions of appointments to be canceled. We'd like to understand better how the VA has managed those cancellations, the status of rescheduling them, and how telehealth is being used to cover those gaps. Congress appropriated over $2 billion to support VA information technology for the pandemic response. The committee has received a high-level breakdown of spending and some lists of hardware that VA requested, but we feel that a more granular details are needed to ensure we are being good stewards of taxpayer funds. While it may be difficult to assess during an emergency, we also need to take stock of whether these funds helped achieve goals that were set out, what more needs to be done to ensure that quality care is still being delivered. The national and local responses to the pandemic, while critical to slowing the spread of the virus, have the potential to cause many emotional stressors. People who already struggle with mental health are now experiencing more isolation, stress, and anxiety, not to mention the possible loss of income as businesses were shut down and jobs were lost. I want to hear how the VA has leveraged telehealth to provide mental health services to those veterans who are most at risk of the emotional impacts of the pandemic. Telemental health is a crucial tool in times like these. And as with much of technology, tools are only as good as people's access to them. There still exists dramatic disparity when it comes to veterans living on tribal lands and in rural areas, namely in access to broadband internet. We've also seen major racial and economic barriers to care when it comes to access to the technology needed to participate in telehealth. We will hear today from some organizations who represent these veterans on how the disparity affects the care of those most in need. We'd like to hear from the VA what it is doing to expand telehealth access to those underserved communities and how it intends to ensure all eligible veterans receive the care they have earned. Ensuring that telehealth works between patient and providers and between systems is important. In this subcommittee, we often speak about interoperability and seamless care. While this hearing is not about the electronic health record modernization, I'm interested in how the EHRM will play a role in the future of telehealth at the VA. I also want to learn about the VA's vision of the future of telehealth and how it plans to leverage resources and partnerships to continue to grow its telehealth program in quality and access. As we discussed earlier, we are living through history right now. Not since 1918 has the world been so dramatically impacted by a global pandemic. Future students and policymakers will be studying this virus and our response for generations to come. And I hope that today provides a helpful data point about how we can work together to improve and expand care for our nation's veterans. We have two panels of witnesses today, one with VA officials and another with representatives of veteran service organizations and the National Indian Health Board. I look forward to engaging on these important topics, and I thank the witnesses for being here. I would now like to recognize Ranking Member Banks to deliver any opening remarks he may have. Mr. Banks.
Thank you, Madam Chair. Let me first say how glad I am to be here in the People's House to examine this important topic. The pandemic disrupted every aspect of our society, and we all have had to adapt in many different ways. The public needs to know that this committee is carrying out its oversight responsibilities with the same level of attention and rigor as it has in the past. I want to thank the men and women of the Veterans Health Administration for their dedication. The path of the virus has been unpredictable and conditions have often been difficult. But as the days turned into weeks and weeks turned into months, our veterans knew that they could count on their healthcare providers at the VA. Telehealth has been a big part of keeping that commitment, and I am proud to be able to say that home telehealth is working. The department has succeeded in fielding the technology to meet the operational need in real time. Our VA witnesses able to mobilize quickly in March and April to expand Video Connect's network capacity. The bandwidth for concurrent video sessions is up by a factor of 5. Daily video telehealth sessions have increased from about 2,500 at the beginning of March to nearly 25,000 today. Although the telehealth help desk was initially unprepared and swamped by the volume of calls, speed to answer is now about 2 seconds, and about 95% of calls are successfully completed. Whereas other healthcare systems simply canceled appointments or postponed them indefinitely, VA was able to convert hundreds of thousands of those consults into telehealth sessions. As impressive as this expansion was, it would not have been possible without the Trump administration's foresight in undertaking the Anywhere to Anywhere initiative in 2017, and without the Mission Act later writing it into law. If we had not broken down the antiquated barriers restricting the provision of telehealth across state lines, we could never have gotten where we are today. I've expressed my skepticism about some of the supplemental appropriations in the CARES Act, but without a doubt, the investments in telehealth capacity are demonstrating their value. With all of that said, there is much more work to be done. Even beyond the pandemic, home telehealth is here to stay. It is not an emergency measure or a last resort. It is a permanent modularity to deliver health care, and the time to plan for the future is now. The days are over when institutional convenience determined priorities above all else. Clinic-based telehealth continues to play an important role, but it is no longer the overwhelming focus. Home-based telehealth means patient-centered care and serving veterans where they are in a manner that meets their needs. Of course, it is not a substitute for face-to-face interactions with a healthcare provider in many situations. Our responsibility is to make sure VA listens to veterans' input and collects comprehensive data to determine how much home telehealth is actually needed and how it should be positioned relative to traditional care, other varieties of telehealth, and community care. The technology investments must be guided by that data. Even with the recent influx of IT dollars, VA cannot afford speculative technology ventures. We have to be building toward a well-established target, not an if you build it, they will come mentality. I think home telehealth is an encouraging example of VA building on a foundation of what already exists. The necessity of VA customizing its own video conferencing software may have been debatable a few years ago, but the fact is we have it now and it seems to be performing. I would like to see more practical problem solving and less pie in the sky in the future. Finally, I want to thank our witnesses on both panels for joining us in person and remotely today. I look forward to exploring the long-term role of home telehealth in VA healthcare and the roadmap for ensuring and enabling technology. Madam Chair, with that, I yield back.
Thank you, Mr. Banks. I would now like to recognize my colleague, Congresswoman Brownlee, Chairwoman of the Health Subcommittee, to deliver any opening remarks she may have. Ms. Brownlee? You may need to unmute.
Good morning from California. Thank you, Chairwoman Lee, and thank you for your leadership in bringing us together this morning. I'm pleased to co-chair this joint hearing of VA's use of telehealth during the pandemic, and I'm very pleased that we'll hear directly from representatives of veteran service organizations as well as the National Indian Health Board today. These voices will provide an invaluable insight as we access VA's efforts, as we assess VA's efforts with telehealth. June is Post-Traumatic Stress Awareness Month. So before we begin, because we're talking today about mental health in addition to other forms of virtual care, I would like to provide the number for the Veterans Crisis Line to everyone watching. The number is 1-800-273-8255, and then you press 1 to be connected to a qualified responder. The crisis line is confidential and available 24/7. And again, that number is 1-800-273-8255 and press 1, or you can text 838-255. Given these unprecedented times, I hope everyone is healthy and staying safe. It's important to have this conversation so that we can all learn more about VA's telehealth expansion during the pandemic, as well as plans for how these new capabilities will be incorporated into plans for reopening and resuming in-person services at VAs around the country. I've heard from one large VA medical center, for example, is looking to keep approximately half of its mental health appointments virtual as the facility reopens for in-person care. We look forward to hearing details from today's VA witnesses about your expectations for telehealth going forward. I'm especially interested in hearing from our second panel about veterans' experiences with telehealth, whether they be positive, challenging, or a mix of the two. We hear that many veterans prefer being able to use virtual platforms and receiving their care for a variety of reasons. But others already had a lack of access to reliable broadband and connectivity before the pandemic hit, and relied on an in-person VA visits to get physical and mental health care. How did the immediate and almost complete reliance on telehealth during the pandemic, however necessary, affect those veterans? Are our veterans in the territories and Indian country being served well by telehealth? How has the reliance on telehealth been for women veterans, many of whom have responsibilities for children in their homes and other concerns, such as experiencing intimate partner violence that might have made telehealth more difficult in the last few months? With that, I welcome all of you. I'm delighted to be here with you, and I look forward to the testimony, and I yield back my time to you, Chairwoman Lee.
Thank you, Ms. Brownlee. I would now like to recognize my colleague, Ranking Member Dunn, to deliver opening remarks he may have. Mr. Dunn?
Thank you very much, Madam Chair. I appreciate the opportunity to be here in Washington with you and Ranking Member Banks, as well as our other colleagues who are participating this afternoon. I will keep my introductory comments short since there have already been multiple statements, and I know we're all anxious to hear from our witnesses. The VA has been a long-time leader with respect to telehealth, the availability of video and telephone visits. Veterans, especially those in rural and remote areas, have had increased access to VA providers compared to the normal civilian population for years. However, in the last 3 months, since COVID-19 was declared to be a worldwide pandemic, the VA has made tremendous effort to expand and improve the department's telehealth programs even further to ensure that veterans who are living under shelter-in-place orders didn't have to delay all of their care. Those efforts have been enormously successful, and the VA should be recognized and commended for them. I'm particularly pleased with the steps the VA has taken to increase access to telehealth for mental health care. It should go without saying that these have been an extraordinarily stressful few months. I'm glad the veterans have not had to go completely without mental health care during this time, and I encourage every veteran who may need additional support to reach out to the VA about setting up either a visit or a virtual visit. I want to associate myself with the remarks and comments made by my friend and colleague from Indiana, Ranking Member Jim Banks, about the technical achievements and the challenges of the VA's telehealth program. I will have several questions about the role of telehealth and what role it will play within the VA healthcare system as more medical centers reopen and our nation continues to move through and beyond the pandemic quarantine. As noted in the written statements from several of our witnesses, we must make sure that telehealth is available and effective for veterans no matter where they reside or what their personal circumstances may be. We must also make sure that in accordance with the Mission Act, veterans are given the option of choosing the care setting that best suits their needs, whether that is a VA medical facility, in the community, or through a virtual visit. I thank our witnesses from the VA and the stakeholder community for participating in our hearing today and also for sharing your perspective on these important issues. For that, I yield back.
Thank you, Dr. Dunn. I will now like to introduce our witnesses we have on our first panel. We have Dr. Jennifer McDonald, is the Chief Consultant to the Deputy Undersecretary for Health in the Veterans Health Administration. Dr. McDonald is accompanied by Dr. Jack Galvin, Acting Deputy Assistant Secretary for IT Development, Security, Operations in the Office of Information Technology. Dr. NEAL Evans, Chief Officer, Office of Connected Care, Veterans Health Administration, and Dr. Kevin Galpin, Executive Director, Telehealth Services, Office of Connected Care. We will now hear the prepared statements from our panel members. I will remind you to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words. And please remember to do so when answering members' questions. Thank you. Your written statements in full will be included in the hearing record, and without objection, Dr. McDonald, you are now recognized for 5 minutes.
Good afternoon, Madam Chair Lee, Madam Chair Brownlee, Ranking Members Banks and Dunn, and distinguished members of the subcommittee. I appreciate the opportunity to discuss the Department of Veterans Affairs telehealth activities during the COVID-19 pandemic. I am accompanied today by Dr. NEAL Evans, Chief Officer, Office of Connected Care, Dr. Kevin Galpin, Executive Director, Telehealth Services, and Mr. Jack Galvin, Acting Deputy Assistant Secretary, Office of Information and Technology. This is a transformational time in U.S. healthcare, accelerated by the unprecedented challenge of the COVID-19 pandemic. VA is proud to be leading the response to COVID-19 alongside our federal partners. And as a result of early proactive planning and the unmatched dedication and resilience of the VA workforce, we are continuing to deliver excellence for the more than 9 million veterans who entrust us with their care. In addition, we consider it a privilege to be the backstop to the nation's healthcare system, serving veteran and civilian Americans in 46 states and the District of Columbia through our 4th mission, providing testing and supplies, and deploying more than 1,000 personnel in support of community facilities in areas of the nation most severely affected by COVID-19. VA has been open throughout the pandemic for all in-person care where clinical urgency rises above the risk of COVID-19. And we are now expanding in-person and virtual services at more than 100 sites. VA's early and proactive commitment to innovation in healthcare delivery is paying significant dividends for those we serve. VA has long been recognized as a national leader in telehealth, and together with our strategic partners, we are rapidly advancing our vision to leverage telehealth to enhance the accessibility, capacity, quality, and experience of VA healthcare for veterans, their family members, and their caregivers anywhere in the country. Continued expansion and deep integration of telehealth into clinical and technical operations is an essential element of our strategy. Telehealth can make it easy and enjoyable for veterans to partner with VA in optimizing health, and it can enhance the delivery of healthcare, enabling expert consultation, facilitating remote management of acute and chronic conditions, and enhancing coordination of care. VA's early investment in virtual technologies, including our personal health record, My Healthy Vet, mobile and other connected applications, and an extensive multifaceted telehealth program, provided a solid foundation for VA's agile and effective response to COVID-19. More than 60% of primary care and mental health providers had already used video telehealth prior to the pandemic, and VA delivered more than 2 million episodes of care through telehealth in fiscal year 2019, with approximately a third of the veterans served living in rural areas. In a matter of weeks, that solid foundation enabled us to increase video telehealth delivery to veterans' homes by more than 1,000%. We have delivered more than 9 million additional virtual care interactions this year over last year, and the numbers continue to grow. Achieving this progress required strong cross-functional partnerships. The Veterans Health Administration and the Office of Information and Technology have worked closely at all levels of the organization to address and stay ahead of the anticipated increase in demand for virtual care. Our IT colleagues strengthened and enhanced the existing environment and are continuously monitoring and optimizing its performance. New and enhanced capabilities improved telehealth visit performance and quality, and new scalable options expanded access, tripling the concurrent use capacity of VA's video telehealth platform and enabling care delivery in a location of the veteran's choosing, such as at home. Importantly, amidst the collective stress of this time, this capacity has allowed VA to provide over 1.1 million telemental health visits to more than 350,000 veterans so far this year. We want each veteran to know that VA is here for them, that we will meet them where we are, and that we will meet them where they are, and that we believe in their resilience. Expanded capacity has also advanced other critical operations, including the Tele-Intensive Care Unit program, which brings remote monitoring and consultation to augment care teams at the bedside of critically ill patients. And meaningfully, the benefits of added technical capacity are not just clinical. This also enables personal connectedness to veterans residing in community living centers or hospitalized to connect with loved ones. VA appreciates the continued support of Congress regarding telehealth, including through the recent Coronavirus Aid, Relief, and Economic Security, CARES Act, which provided the supplemental funding needed for VA to invest in enhancing and expanding our systems and technology. Recent legislation, such as the Mission Act, which authorized anywhere-to-anywhere telehealth, has also been pivotal to advancement. VA is committed to providing excellence for each veteran in our care, especially during these unprecedented times. We will continue to lead the way forward, and we are grateful for your continued support, as it is essential to providing care for veterans and their families. This concludes my statement. My colleagues and I are prepared to answer your questions.
Thank you, Dr. McDonald. A reminder to my colleagues that members should pause 2 to 3 seconds before speaking so that all of your questions are captured. I will now recognize myself for 5 minutes for questions. Congress appropriated supplemental funding to the VA to support operations during the pandemic. I would like to better understand how the VHA and OIT allocated funding to support telehealth. So for Dr. McDonald, of the funds appropriated for VHA activities, what funding was allocated towards telehealth activities specifically?
Madam Chair, I will say that nearly $6 billion of the appropriated funds has been allocated to our field to meet the demands of the pandemic, including for telehealth, and an additional amount was dedicated to the program office, which I will pass this to Dr. Gelpin to delve into a bit further. But I just want to make a note that we so appreciate the foresight of Congress in appropriating these funds and enabling VA to move with agility. We had what we needed, and we were able to focus on the operations and the people in front of us, and we're grateful for that. Dr. Gelpin, would you speak to the telehealth program office funding?
Yes, thank you for that question. So as Dr. McDonald mentioned, the CARES Act funding has been critical for enabling us to support both veterans and providers during the transition. So since March 1st, we've spent over $38.9 million of the CARES Act funding, and that has gone to, for instance, providing over 20,000 4G connected iPads to veterans, again, to support them if they don't have the technology or the internet to participate in telehealth operations. For providers, we've provided over 8,000 iPads, 24,000 webcams, 22,000 headsets, 10,000 speakers. We've also, as mentioned in the comments, we've been able to expand our help desk to make sure that we could take calls from both veterans and providers to help them get set up and comfortable with telehealth. We have funding to fund research to make sure that the actions that we took during the pandemic have proven to be valuable. And we'll be using the funding to expand our telecritical care program, which is going to be critical to fortifying our ICU services, both during this emergency and future emergencies.
Thank you, Mr. Galvin. In response to the pandemic, Congress appropriated $2.15 billion to OIT for VA information technologies, and this money was intended to support increased telehealth, and call center capabilities to, just as Mr. Galvin had identified. We have been seeking some clarification on how the money had been spent. Can you explain what was the VA's trajectory on telehealth before the pandemic, and how has this changed with the infusion of the $2 billion? This is for Mr. Galvin.
Yes, thank you. Thank you, Chairperson Lee. So from an OINT standpoint, as Dr. McDonald indicated, we were in very much collaboration right from the start to assess what the key infrastructure needs were. OINT did receive $2.1 billion through the foresight of Congress. We were able to first leverage it for video conferencing enhancement. Our on-premise solution was tripled in capacity, as well as providing a scalable option in the cloud. We also are pursuing 200,000 laptops for the enormous amount of increase in the number of remote users, including telehealth users. We also have invested heavily in bandwidth modernization and in key critical care areas, such as telehealth, tele-ICU, as mentioned by Dr. McDonald. And finally, we are poised to scale a sustainable expansion of telehealth, as well as other areas, including the vast increase in telework. We experienced about an 80,000 person uptick in the amount of people that worked in a telework environment. Much of our infrastructure investment is primarily for infrastructure that supports the remote end user experience. Included in that investment is also application monitoring that helps us track utilization against established capacity, so that we can be proactive in our expanse and reactive to any problems that may occur. So for instance, in our telehealth capacity, coupled with our on-premise system, as well as our cloud, we're running at about 45% capacity today, and poised to scale very rapidly with the COVID supplemental expense. Thank you.
Thank you, Mr. Galvin. My time's expired. I now recognize Ranking Member Banks.
Thank you, Madam Chair. Dr. Evans, I sent a letter on February 5th asking which patient portal the VA intends to select for the future. The My Healthy Vet portal that VA has been using for many years, or the Healthy Life portal from Cerner. I framed the question in terms of which one can best integrate with va.gov. Given our topic today, I also want to emphasize the importance of integrating with VA Video Connect. I have still not received a response, so I ask you, which patient portal is it going to be?
Sure. So let me speak briefly about the patient portal. It was an important part of our response, frankly, to the pandemic. My Healthy Vet, which is integrated into VA's front door, digital front door, va.gov, has been our patient portal for more than 15 years. It's a single common experience for veterans, regardless of what facility they're receiving care from. And frankly, it also has been an important part of how we've been able to reach veterans during this pandemic. We've seen a 9% increase in unique users, interacting 26% more with the portal over the course of the pandemic. In addition, we saw more than 2.1 million additional secure messages sent back and forth between patients and providers during the pandemic. The portal has been an important part of our strategy to reach patients and to take care of them in their home. To your specific question, as we move forward with electronic health record modernization, at the Mann Grandstaff VA Medical Center, the first site to go live with the full electronic health record solution, the portal experience will initially use the Cerner Healthy Life portal, which will go by the name My VA Health.
which will divide the portal experience within the VA. There will be two different experiences, one for those who are engaging at a site that has Cerner as the underlying electronic health record, and one that has Vista as the underlying electronic health record, which will be My HealthyVet. We don't think this is the right long-term solution. I think it's important for VA to continue to operate as an integrated health system, and there should be one single common portal. It should be transparent to the veteran what site they're receiving care at, what the underlying electronic health record is, and we should have all of the health portal experience fully integrated into va.gov. We are currently working to achieve that vision using a combination of both the technology that supports My HealthyVet as well as the underlying technology within Cerner.
All right, I have a similar question about VA Video Connect. You considered replacing it in 2017 when you were formulating the Cerner contract, but you decided to keep it. How was that decision made, and do you believe it was the right one in hindsight?
Yes, I absolutely believe it was the right decision, and I think we have seen the evidence of that. The evidence of a standard national enterprise solution for virtual care, in particular for home video visits in the context of the pandemic. And the fact that we can use VA Video Connect and integrate it into Cerner will allow us to continue to deliver a consistent experience to veterans, regardless of what medical center they're receiving care from, but will also enhance the experience for the providers using the modernized electronic health record. So, in brief, by integrating VA Video Connect into Cerner, providers who are using Cerner will have video care more deeply built into their workflow, into their daily work as they manage their schedule, which will increasingly be a blend of both in-person care and virtual care. And we will be able to continue for the rest of the enterprise that is still using Vista to deliver the same video experience.
Can you give us a rough guess on how much you've spent on Video Connect since you created it?
I don't know the answer to that. I might see whether Mr. Galvin knows anything on the IT spend for VA Video Connect.
We can ask you to submit it for the record.
Sure.
I appreciate that. Last question. The VA has been issuing tablet computers to veterans to increase telehealth access for at least 5 years. How many have you bought so far, and how many are still in use?
We have, I believe, 40,000 iPads that are in circulation. And if I recall, I think there have only been 100 some that have been lost or taken out of use. But I will ask Dr. Galpin. He has the exact numbers and can provide those to you.
My time has expired, so we'll just ask for that to be submitted for the record. Okay. Thank you.
Thank you, Mr. Banks. I now recognize Ms. Brownlee for 5 minutes.
Thank you, Madam Chair. My first question is to Dr. McDonald. Doctor, I've been focused a lot on Indian country in this, as we have been having hearings in and around the pandemic. And so I am, with regards to telehealth, I'd like to hear what specific, and I really mean specific kind of outreach that the VA has undertaken to reach out to territories to ensure that they have access to telehealth. And then, and I hope that in your answer, you'll also address the issue of providing equipment and iPads, computers into Indian Territory. I know that the Navajo Nation and Cheyenne River both have been maintaining very strict travel restrictions because they have been severely impacted by this virus. I think our Native veterans in general have been severely impacted by this virus. So if you could let me know, what VA has been doing with regards to providing the necessary equipment to provide the telehealth in Indian Territory.
Madam Chair, across the course of the pandemic, We've been grateful for the partnership with the Indian Health Service and also directly with tribal nations, including, as you mentioned, the Navajo Nation. And as our personnel deploy in support of these areas, including the Navajo Nation, we have just undertaken a mission through the Indian Health Service with the Apache Nation, the Awodum tribe, and also the Hopi Nation. We are engaging there and delivering that connectedness with our personnel as they reach the ground. We are also bringing that equipment and necessary PPE, connectedness virtually, the devices we need along with us to make sure that those veterans have access to the full range of care that we can provide in VA. And as we have expanded services across the pandemic, as you may have heard, we have been able to expand not just our primary care and mental health and specialty services, but also our tele-ICU services. Our presence there is a first step, and the connectedness that our personnel bring is a first step. But we are very much looking forward to further expansion and growth in these areas and connectedness. This is also something I will acknowledge that VA can't do alone. We recognize that for tribal nations and really for many reaches of America, that the veterans we are aiming to serve and increase connectedness for are also the same areas where members of tribal nations and other Americans need that connectedness. We are aiming to partner across the federal interagency, including with the Indian Health Service, and with state and local and tribal nations and their governments to make sure that we can bring that connectedness to them. VA has a role in this, and indeed a leadership role that we intend to serve, but we look forward to collaboration with our strategic partners to fully achieve what's needed here.
Well, thank you for that. I'll be very interested to know how you expand, deliver more equipment, increase connectivity. I'm going to be keeping a sharp watch on this. I just feel like our Native veterans have been severely impacted, and it really requires a razor sharp focus and effort on behalf of the VA to make sure that we are providing the health care that they so desperately need. My last question, and I'm running out of time here, is I had the Women's Veterans Task Force, and I was struck by Ms. Church's testimony and her Minority Veterans of America written testimony, where she talked about challenges around telehealth and domestic abuse survivors, and making sure that there is a safe environment for those who may be impacted under those circumstances. It's a double-edged sword. We've got to provide the safety, and these are people who probably need telehealth, most desperately. So can you talk a little bit about what measures have been taken to provide a place of safety in an online environment?
Yes, Madam Chair, health equity and that true north of safety, of veteran safety, is paramount as we expand this technology. And I will turn to Dr. Galpin for the specifics on this, but we've been proud to see that across this expansion, we are continuing to deliver telehealth equitably across the demographics in VA. Specifically, women veterans' participation with telehealth is growing. That tells us there's interest. It also tells us there's access. And we are specifically pursuing options, including with the Veterans Crisis Line, for veterans to be able, even virtually, to tell us if they're unsafe at home and connect to a safe environment and a safe place where they can receive help from us. I'll pass to Dr. Galpin for the specifics.
I think my time has ended, so I think we'll have to follow up outside this hearing. And I apologize, Madam Chair, for exceeding my time, and I yield back.
Thank you. I now recognize Dr. Dunn for 5 minutes.
Thank you very much, Madam Chair. Dr. Evans, I think we can all agree that telemedicine saved many medical practices during the last few months to the extent they were saved. I'm a huge fan of telemedicine when done properly, and I believe properly means that there's a prior established relationship between the doctor and patient. Stipulating all of that, we also have to admit that the rate of diagnosis of cancer nationally is down 30% year on year. And I don't think any of us believe that cancer is occurring 30% less often than it did last year. And this reflects a failure to screen and diagnose our patient population. I'm a urologist. it's really tough to do a prostate examination by telemedicine. I'm concerned that we're being lulled into equating telemedicine with medicine. I'm concerned that we may become complacent and think we can substitute these comfortable visits where we can call it in from our couch at home, and we find reasons to not do the hard work of being a doctor to our patients in person. What are we doing at the VA to catch up with our screening and the delivery of this vital, normal care?
I wholeheartedly agree that telehealth, the value of telehealth occurs when it is integrated into the full delivery of healthcare. So it's the integration of virtual care, which brings convenience and improved access to care with in-person care, with existing relationships. And that has always been our goal in the VA. In fact, before the pandemic, 60% of our primary care and mental health providers had completed at least one video visit. All of our primary care mental health providers and frankly specialty care providers were participating on the portal, exchanging secure emails with patients, and telephone care is used extensively across the enterprise, both before the pandemic and
I'm familiar with a lot of what the VA does because I was a doctor in the VA or in the military. I want to know what you're doing to catch up.
Right. Well, I think so there's a couple things. One of the advantages of video visits and our video platform is that the video platform can support multiple team members engaging with the patient in a single visit. So we can catch up on some of the screening tests that don't require screening questionnaires, mental health screening, et cetera, that does not require an in-person exam. And we can also work to bring people in for necessary lab tests. As Dr. McDonald mentioned in her opening comments, the VA has never been closed. We're fully open for business. I regularly have had my patients come in and have lab tests done, have imaging studies done when it is necessary, when that study is important enough that it needs to be done and rises above the risk.
Good. I think that's important. So I mentioned that I'm a fan of telemedicine for many reasons, but one of the reasons is the rural population that I serve, and we have so many veterans in our rural areas. When we talk about the rural population, we have to realize that the video connections are, very, very dependent on broadband, and we don't always have that. So I would like to know if there's any special video requirements in the VA to perform telemedicine, or what percentage of your telemedicine is done by audio now, and do you plan on controlling that going forward?
Sure. So so I would say that I'll give you an example. During the course of the pandemic, if we take from fiscal year 2020 and we look at telephone-based care, the VA did 16.7 million telephone visits, 1.9 million video visits, and 15.2 million secure emails. And so the balance, we still do an awful lot of telephone care. That video number,
that does not surprise me. And by the way, with a rural population, it pleases me to know that those veterans do have access to you and will continue to, I trust.
Correct.
Excellent. So I think that's outstanding. I want you to consider what some of the challenges are you're going to be facing as you ramp up the huge number of telemedicine visits, and please keep us informed what we can do to help you with that. And with that, I'm running out of time. Madam Chair, I'll yield back.
Thank you, Dr. Dunn. I now recognize Representative Lamb for 5 minutes.
Thank you very much, Madam Chair, and appreciate all the panelists being with us today. I wanted to ask for an update on the project with Philips to install I probably will have the terminology wrong, but to install the telehealth portals, I guess, in some VFW and other similar type of locations around the country. One of them is here in Western Pennsylvania, up north of me. And I think the project has a lot of promise. So if you could give us an update on where it's working and how, and if it requires extra staffing or assistance or any obstacles that you're running into.
Congressman, yes, this is our Atlas program, and I will turn to Dr. Galpin.
Yeah, and thank you for this question. So the Atlas program, it's advancing telehealth through local area stations, and it's actually one of our initiatives in rural areas to help overcome the digital divide. What we're essentially doing is creating access stations where a veteran could show up, where there's already technology, there's already internet, so they can come in if they don't have those services at home, and they can get their VA care from those spots. So we are working with Philips, we're working with veteran service organizations, we're working with Walmart, and we look partially through what Congress was able to do with the CARES Act to help bring out some other partners who want to partner with us on that. Initially with the pandemic, we did close down those sites due to concern about infection. We are beginning now the process of opening them up. So Eureka, Montana is open for business as of this week. We've been working with infection control, with our partners to try and make sure that these are safe spots for veterans to go. We do see this as a huge opportunity going forward to expand the footprint of VA. We also think it's a great place, even for veterans who might have internet and technology in their house. If that's not a good therapeutic environment for them, because of something happening at home, this would be a safe place where they could go in their community to get care, not have to travel all the way to the VA if it's a far distance away. So we are very excited about this project, and yeah, I mean, I think there are definitely areas that we'll be partnering again more with people in the community, but again, looking forward to moving it forward.
Is there capacity to expand to other places this year, or are you guys kind of flat at whatever the number is now?
You know, we're looking for opportunities. I think our first goal right now is to get all the places that we already had on our list open. Once we achieve that, then we'll be looking to expand again.
Do you know what that number is by any chance?
I believe it. I don't want to say and not be accurate. I believe it's 9, but we can make sure I correct that in the record.
Okay, and what kind of usage are you seeing for the places that are up and running right now? I mean, do you have any rough way of describing that? I'm not like looking for anything exact, but
yeah, we were just opening when we really got hit with the pandemic. So I mean, the usage to date has been small, and we are just reopening now. So I think we have a ways to go before we can really assess how effective this is.
Okay, and do they have staff or technical support at the site kind of regularly, or is it more of an on-call type thing, or how does that work?
Now, there's expected to be an attendant on site to help the veteran with the technology there to get them in the room. That is one of the areas where we're going to look for partners to make sure that we have the right staffing so that there is support on site. Not someone in the room during the appointment, but someone who can, again, greet them, get them started, make sure the appointment goes well for them.
Okay, and when can we expect kind of an initial evaluation by VA of this program and how well it's working?
You know, I don't know the exact answer to that. I know it's important for us to do that evaluation. We need to give it some time before, so we can get up the numbers and make sure we can get some quality experience scores back on it.
Okay, thanks. Yeah, I just would like to make sure there's a plan in place to be sure that we're evaluating the usage of it and the functionality and whether it is a good idea for expansion. Because if it is, you know, we wouldn't want to waste any time, obviously. So appreciate that information and your efforts. And Madam Chair, I yield back.
Well, thank you, Mr. Lamb. I now recognize Dr. Rowe for 5 minutes. Dr. Rowe. Have you unmuted? Dr. Rowe, we can't hear you. Can you unmute? Is that? There we go. Yep, now we can. Thank you. You'll need to start over, Dr. Rowe.
Thank you, Chairwoman Lee, and I also want to compliment my good friend, Ms. Brownlee, on her new glasses today. Look great. A couple things that we have that I just want to bring up quickly. is that I think that I'd like to know from Dr. McDonald or Dr. Galpin or any of the folks who are on the panel, what has been your greatest obstacle so far with the greatest challenges that you've had?
Dr. Rowe, the challenge in the scale of reaching 1,000% and the speed at which that needed to happen over a number of weeks was significant. What we needed was for our workforce to lean in, and they did. We needed the capacity of our technology to be expanded, and IT came through for us in close partnership with us. And we needed the processes of the organization to evolve rapidly to support this. And our leadership at all levels of the organization, not just in central office, but even and especially in our field, leaned forward and led this charge forward. I will pass to Dr. Galpin to describe some of the additional opportunities we see moving forward, but those primary barriers that were in our way that we needed to surmount to scale this have actually been overcome. Dr. Galpin?
Yeah, no, I appreciate that. I think I can approach this in two ways. So, I mean, as Dr. McDonald mentioned, we definitely had some challenges that we needed to overcome. And that's despite being a very large telehealth operation that has a national enterprise video solution for the home. We have a home telehealth program that's across the country. We have an anti-text messaging protocol system. And we have a telecritical care system that's over about 38% of our ICUs. But despite that, early on, we definitely recognized that we would not initially have the capacity to increase our supply of video visits to where we anticipated it would be. And that is why we worked week over week with IT to make sure that we could stay ahead of that demand. We definitely ran into capacity strain on the system at time. We saw that. Fortunately, I think with all the great work that was done, we are now on the other side of that and excited to be there and able to expand even more. We had, as previously mentioned, we had challenges at the help desk. We had so many calls coming in because so many people were adopting the technology that we had to really almost quadruple the size of our help desk. It's somewhere between triple and quadruple to make sure we could handle the load. The digital divide is always a challenge. We could have the greatest telehealth services in the world, and all of our providers could be prepared to deliver that. But if the veteran doesn't have the technology on their side of the equation, it doesn't help the individual. And as always, it's despite the Mission Act and the great advances that allowed us, we still are forced to navigate through a very complex legal and regulatory environment. That is something that is a challenge despite our very clear mission, and something we would certainly love to work together with Congress on. We think that would be a huge advance.
Dr. Galpin, you brought up something I was going to bring up, and I don't have any idea. Congresswoman Lee just cut me off from my side here because I can't see how much time I have left, but you brought up something I think
You have a minute 40.
Extremely important. And in the Mission Act is the asset review. I think the coronavirus that we've seen, both in the private sector and the public sector, is going to transform how we as physicians practice medicine. I've seen it in my own practice. Dr. Dunn mentioned that. I think the previous physician-patient relationship is absolutely paramount to make this work. But it's going to change what the VA looks like if we're doing as many, for instance, mental health visits. There are certain things that I think telehealth work extremely well for. I'll give you a roundup next week. Next Monday, I have my first telehealth visit. It saves me 10 hours in the car driving back and forth to a specialist. So I'll let you know how that goes. I'll give you a report. But I think we need to sit down now and do a deep dive before we do the asset review to see how this technology is going to change the VA's footprint and needs. And the other thing I want to ask, has this expanded the VA's provider base? In other words, has this made us more efficient with the providers that we have? I may not have time, and I'll stop with that.
Dr. Rowe, thank you for the acknowledgement on the Air Commission of that strategic conversation. As you've seen from us with the work on the Air Commission thus far, there's been very deep listening occurring to our field leaders and our field front line on the operations and what they need and what our strategy will be going forward. That, of course, has evolved across the duration of the pandemic, and that listening is, again, what we will do with them, and we'd like to have that further discussion with you. And yes, we are proceeding forward toward a future where our providers are able to have the flexibility of working from home. To your point, we've been able to recruit more than 20,000 new hires into VA across the course of the pandemic, more than 3,500 nurses, more than 500 physicians, and giving them the flexibility to be recruited in an area where we have that capacity and bring that to rural areas, to tribal nations, to those areas of the country that really need it, means we can expand our workforce and recruit the best of the best to us.
Thank you. I yield back. Thank you, Chairwoman Lee.
Thank you, Dr. Rowe. I now recognize Mr. Rose for 5 minutes.
Thank you, Madam Chairwoman. And of course, thank you to all my colleagues for setting this up, and for those who are testifying. Thank you for your contributions and for your service. I want to start off with a question that has garnered quite a lot of frustration in my district amongst our veterans, and that's related to the compensation and pension exams, CNP exams. Now, since COVID, we have transitioned, or you have transitioned, to CNP exams, which has been incredibly valuable. Veterans in my district were being forced to drive out of state, sometimes drive multiple hours to take these exams. And what COVID has showed us is that that's absolutely not needed. So my question is simple. Is the VA planning to keep common sense measures like this in place after the COVID crisis is over?
The short answer, Congressman, is yes. We work closely with VBA on this, and this has been an opportunity for us to look at those operations and maximize the use of telehealth. There are a few specific areas where we are legally mandated to conduct those visits in person, including for prisoner of war rate change appeals. But beyond that, we intend to incorporate telehealth in the common sense way and make this easy for veterans, as you mentioned.
So just to kind of get you on record here a little bit, you're telling me that CNP exams will now be permanently in place going forward?
Congressman, I believe that's a decision at a higher level than I am. There will be a brief on this later in the week, this week. And yes, we intend to incorporate telehealth. How permanent that is and for which specific veterans and conditions, I will defer to the answers on the leaders who will brief you.
Okay. I like your first answer better than your second, but I guess we'll have to go ahead anyway. I want to talk about telehealth for our seniors. Now, it is no shock. We even see this in Congress, that some folks aren't technologically adept and not yet able to kind of advance with the times. What services is the VA offering to help our seniors install the technology or learn the technology necessary to engage in telehealth procedures?
Congressman, I'll answer briefly and turn this to Dr. Galpin. We believe our geriatrics model in VA is a leading model in the nation for several reasons. Operationally, and of course, we've made great strides in keeping our veterans in our community living centers and in state veterans homes and community nursing homes across the country safe. And part of the way we've done that is via telehealth and making sure that they're connected back to VA and back to the care and services that support them. That also includes caregivers caring for some of our elderly veterans and making sure that they have the supports and the services they need. Beyond that, I'll turn to Dr. Galpin.
Yeah, well, I appreciate this question. I think there's several ways I can take it. So first of all, is just as far as helping veterans with the technology, irrespective of age, we believe the experience of telehealth starts with that first discussion where the provider says, would you like to do this? Would you like to consider getting your next appointment through this modality? And from that point, we want to make sure we have options to help any veteran who needs help get assistance with the technology. One of the things our National Help Desk does, which is also repeated at local facilities, is that veterans can call up and actually do a test call with one of our technicians. So if they've never used the technology before, they can get on live with the person, download the application if they need to, do a test call, get through any of the technology hurdles to make sure that they're prepared for the first visit. So we want to double down on that. We want to fully integrate that into that total experience from end to end. So no matter where you are in the country, you can have that hand-holding experience and make sure you get the assistance you need. I think, what Dr. McDonald had mentioned is work we've done with state veterans homes and CLCs. And again, that's a special population that we know is at risk during this pandemic. And so we've tried to make it easier to set up telehealth services at those sites. We've eased some of the administrative restrictions and developing agreements. We've sent out technology to those sites as loaners from the VA, and we've seen, I think, and actually let me pull up the numbers here, 121 of the CLCs and state veterans homes have put or have an agreement in place for telehealth, and we've seen 128 of them actually start delivering a service. So again, it's an important population. We want to make sure everybody feels comfortable with this technology. And no matter what age, there are people who start out at a place where they need more help, and we want to be able to help them.
Okay, thank you. I presume I don't have much time left, so thank you again for everything you're doing. I yield back.
Thank you, Mr. Rose. I now recognize Mr. Watkins for 5 minutes.
Thank you, Madam Chair. Dr. McDonald, I applaud your success in building out the VA's Video Connect capacity so quickly. It usually takes the federal government 3 months to put together the requirements to hire a contractor to start doing the work. VA actually finished most of this work in 3 months. As the medical centers reopen and the demand for home telehealth stabilizes, what's your strategic plan? Where do you want telehealth and VA Video Connect to be in a year? Where would you like to see it in 5 years?
Thank you for this question. This has been such an opportunity for us, and I want to just acknowledge that capacity that has been built, our ability to do this on the health system side has been entirely technology enabled. This is thanks to our IT colleagues' partnership with us in expanding that capacity and really hearing and listening to our frontline provider needs that this has been achieved. We intend to sustain and grow from here. As much progress as we have achieved, that 1,000% already, we actually believe this is the beginning of a longer trajectory and that there's more expansion possible in specialty care, for instance, delivered at the bedside in inpatient settings and in emergency care settings. And I'd love for Dr. Evans to expand on the future of VA Video Connect and where we see these tools fitting into that vision.
I think, as was mentioned a little bit earlier, the value of telehealth occurs when it's fully integrated into the existing healthcare system, when it connects veterans with their healthcare providers, with their healthcare team, and I mean that broadly, with their nurse, their social worker, their pharmacist, their specialty care provider, their primary care provider, their mental health provider, when this is just a fabric of how we deliver business and how we care for the veterans that have entrusted their care to us. We want to get to a point where this is basically where telehealth, video care into the home is the same, frankly, as having a telephone or the ability to send an email, where every patient can receive care either by connecting electronically with their healthcare team, by telephone, by video, that is telehealth, or in person, and that we're doing that in a way that makes the most sense to achieve the best clinical outcomes for the veterans that we serve.
Dr. Evans, as VA goes live with the Cerner EHR, how will the VA Video Connect integrate into that?
The VA Video Connect will integrate deeply into the electronic health record to provide some specifics. When a patient calls to book an appointment or asks to book an appointment online at a Cerner site, they will have the option to book a video appointment. And in the background, within the Cerner-based electronic health record ecosystem, all of the transactions that need to occur to set up that video visit will occur without any added effort needed by the scheduling clerk. Emails will be sent to the patient with reminder emails that come out prior to the visit about how to access the visit, information about how to access the test call that was mentioned briefly before. And when it comes time for the visit, the provider will be working within the Cerner electronic health record. They may have just had a face-to-face visit prior to that and a telephone visit prior to that, but when they get to the video visit on their schedule, there'll be a big old green button there that they can press to enter the video room to start the visit with their patient. So the advantage is the integration of video care right into the workflow of clinicians within the modernized electronic health record.
Dr. Galpin, does VA have any modeling to predict the future demand for home telehealth versus clinic-based telehealth? If so, what data does the modeling rely on?
You know, it's an interesting question, and it's one that comes up a lot. Is what is the right number? Like when do we say we've gotten where we need to go? And I don't think we know that yet. So I think we're at the point where what we want to do is get to the point where that this is just part of the integrated solution or an integrated solution for care, so that a veteran and a provider can sit at every visit and say, okay, how do we want to deliver the next step of care? Is it by phone? Is it in person? Is it by video? And all those options are equivalent. They're all equally simple. They're all accessible. And at that point, once we achieve that, then we'll start knowing, you know, what is the preference of the veteran? What is the clinical capability of the provider to deliver that service? I don't think we have that data yet, or that ability to predict. I mean, I've definitely seen people putting out predictions, you know, 30%, 50%, but I'm not confident we yet know. I'll also add that, you know, as the technology improves and we can do more and more into the home, you know, we're beginning to add stethoscopes and you know, other type of digital technologies, pulse ox. The more we can do in the home, that threshold is going to keep rising. So we're not there yet, and it's going to change.
Thank you. Thanks to the panel. Madam Chair, I yield balance.
Thank you. Thank you, Mr. Watkins. I now recognize Mr. Cisneros for 5 minutes.
Thank you, Madam Chairwoman. Thank you all for being here today. Dr. McDonald, in your testimony, you state that the VA video appointments have increased by more than 1,000% since the start of COVID. With this unique challenge veterans face, coupled with the stressor of this pandemic, how has telehealth been used in VA suicide prevention efforts during this time of COVID?
Congressman, this is such an important question, and thank you. As a veteran still close to the unit I served beside, I've seen the stress of this time directly, of course, at a system level, but also anecdotally and personally. And I've also seen the resilience. And what I've been most proud to see from VA is not just that we are reaching out and making telehealth available, but that we're making it enjoyable and easy and safe. What once would have taken a veteran to come to us, walk through the door, have the courage to be there in person and be seen in order to establish care, now can be done in the privacy of that person's living room or at an Atlas site if home is not the right environment. This has opened up, even for those I personally know, the ability to engage in care in a new way. As I mentioned, we've delivered more than 1.1 million telemental health visits so far this year, and we're seeing that continue to grow. Our providers are reaching out proactively across their panels, including for those veterans most at risk, those that they know, as it's PTSD Awareness Month, those that they know face significant challenges, those that may face financial stressors during this time or face homelessness, to make sure that even in a socially isolated setting, that these veterans are connected with us and that they know VA is here for them. And what I'm most proud of is that I'm seeing that augment veterans' own resilience.
So regarding the VA's Veteran Crisis Line, will you speak to how this program has been adapted during COVID? Are veterans able now to, rather than call the crisis line, are they also able to dial up and speak to somebody live over a virtual meeting?
They are with their care teams, yes, sir. And actually, the data from the crisis line, we believe, is part of the way we know that this is working, that our outreach is working. The crisis line saw an initial bump in calls as the pandemic started, not surprisingly. That has actually normalized, and we believe that this is in large part thanks to the significant amount of outreach that our mental health providers, that our rehabilitation counselors, that our social workers have done to make sure that people are safe. The Veterans Crisis Line has also evolved their operations, and they're making sure to do that warm handoff to the primary care provider or mental health provider after a veteran calls them.
Great. So will you also elaborate on the VA's COVID Coach app, which I understand is a smartphone app developed by the VA meant to help veterans with coping skills for self-care during this time of COVID? What has been the outreach and marketing for the COVID Smart app to veterans?
Yes, sir. Dr. Evans is the expert on this one.
We have a text messaging program that's named Annie. It's named after Annie Fox, the first woman to be awarded the Purple Heart. She was the chief nurse at Hickam Field during the attack on Pearl Harbor. And Annie sends text messages to veterans that they can respond to. And these can be tailored and customized. The protocols that come from Annie can be tailored and customized. And as soon as the COVID pandemic was coming into focus, and we began to think about the potential impact of COVID, we built two specific Annie protocols. One to help to provide coaching and advice to veterans as they were trying to cope with the impact of the pandemic, being isolated at home, et cetera. And one also to help monitor those who were quarantined or isolated at home with COVID, who were healthy enough to be at home, but needed follow-up. And I'll read you a couple quotes from the survey. This gives, when we asked veterans about this, Annie, this gave me peace of mind, a feeling of safety that I wasn't alone. Annie always provides good info that one can use, trustworthy information. Information is power, and Annie's daily messages are inspiring. I feel less anxious knowing that I have this form of connection with VA healthcare during this difficult time. So it's been pretty inspiring to see what simple messages and trusted information delivered to veterans, the impact that has had on individuals as they've been struggling during this.
So I'm running out of time here real quick, but I do want to ask, do you have data on how many veterans have been able to download this and its effectiveness?
Yes, we had, I believe, 3,500, no, that's Home Telehealth with 3,500 users. 6,234 veterans interacted with the coronavirus virus precautions protocol, and 1,254 with the coping during COVID protocol.
With that, I yield back.
Thank you. I'd like to thank the panel for being here today, and thank you for your support of telehealth and being out in front and making sure that our veterans are, that we've adapted to provide them with care. We're looking forward to continuing to shine transparency on the funding that we give the VA, but also how we're going to interact with the new electronic health record, the new scheduling program, and obviously where telehealth is going to take us in terms of opening up access in the future for Veterans Affairs. So thank you all for being here. Appreciate it.
Thank you, Madam Chair.
You are now excused, and I will call up our second panel, and we will take a brief recess while we set up. To call this hearing He is the chief of the Valdez tribe in Alaska. He also serves as the vice chairperson of the National Indian Health Board. Lindsay Church is the co-founder and executive director of Minority Veterans of America. Marquis Bearfield is Assistant National Legislative Director of American Veterans. Tammy Bartlett is the Associate Director of the National Legislative Services for Veterans of Foreign Affairs. We will now hear the prepared statements from our panel members, and I will remind you to each pause 2 to 3 seconds before speaking so that the microphone picks up all of your words, and that you can also pause when answering questions so we can capture your complete response. Thank you. And your written statements in full will be included in the hearing record. And without objection, I now recognize Chief Smith for 5 minutes.
From Valdez, Alaska. Good morning, Chair Lee, Ranking Member Banks of the Technology and Mobilization Subcommittee, and Chairwoman Brownlee, Ranking Member Dunn, and member of the Health Subcommittees. On behalf of the National Indian Health Board, thank you for the invitation to testify on VA efforts to provide health care during COVID-19 pandemic. My name is Chief William Smith, of Valdez Native Tribe. I am a Eyak Alaska Native, and I am also a Vietnam vet. I speak firsthand about the challenges facing American Indians and Alaska Native veterans in accessing care during this. As Native veterans, we are entitled to the health care services from both the VA and the Indian Health Service. There are over 217,000 Native veterans that have used the VA service for health care. This is about 2.5% of the total VA service population. And in Alaska, we have a special agreement with the VA to administrate health care to all veterans, not just Native veterans. Alaska also has the highest per capita representative veterans in the nation, with about 70 to 90,000 veterans. However, in Alaska, only has about 35,000 enrolled in the VA benefits. In order to reach Native veterans, the VA should support services to them by funding the VA Office of Rural Health and support such program as the Tribal Veterans Representative Program. My written testimony highlights many things that the VA and the Indian Health Service have in common. One is that both continue to rely on the same underlying health IT system, and both are in transit phases of their electronic health records. The VA and the Indian Health Service have had mandates of memorandums of understanding in place for almost 2 decades regarding care for Native veterans. 4 of the 12 goals under the MOU are related to health IT and telehealth, including both agencies are required to collaborate on the implement of new technology around telehealth to coordinate health IT development to improve interoperations between the VA and the Indian Health Service, electronic health records, and to jointly develop a new health IT application and technology. Both in practice, there remain significant challenges to coordination in these areas that limit the quality of health care for Native veterans. I'd like to share a couple of the facts highlighting these challenges. Lack of participation in funding. The VA service population is about 3 times the Indian Health Service population. However, its annual funding is roughly 13 times more than the Indian Health Service funding. One COVID specific example, Congress gave the VA over $15 billion for medical care, including $3.1 billion for health IT, whereas the Indian Health Service got roughly $1 billion, of which only $65 million was for health IT. Lack of Indian electronic health records interoperability. Neither agency has estimated targets to measure programs on any of the specific goals under the MOUs. Without targets, how can we measure progress on health, IT, and telehealth cooperations? Challenge issues were presented before COVID and made worse since becoming tribal programs have received fewer resources to respond to the pandemic, and tribal communities have been hit hardest by this crisis. According to the CDC, Alaska Native and American Indian people have the highest hospital rate of ethnicity nationwide. Our people have the second highest COVID death rate. If tribal nations were states, the 5 states with the highest infection rate per capita would be tribes. We have no clear vision of how our Native veterans are doing. The VA has not yet to release race-specific information on COVID infections. We know as of June 22, the VA has 2,332 total active cases, and it is averaging about 127,000 weekly telehealth visits. Since March 1st, the VA has increased use of telehealth by 1,065%. It is not likely that there have been equilibrium of access to telehealth for Native veterans. According to the FCC, only 46% of the House of the tribal lands have access to broadband in Alaska. It is even more extreme, with only 33% in rural Alaska have access to broadband service compared to nationwide, where 61% of the rural areas have broadband services. It seems that the VA also fails to act on the existing MOUs with Indian Health Service or the tribes to improve telehealth under COVID. The Navajo Nation is one of the recipients of the technology of personal assistance. The VA reported delivering 100 masks to Native veterans on Cheyenne and Standing Rock land. That is it. There are no further information on the VA COVID website and the effect acted of the MOUs and the deal. And I know my time is up, but I have just a couple of more deals. Information we heard from the Native vets during COVID. Many Native vets reported frequent connection issues with including drop calls. Native veterans reported use of healthcare is hindered by the lack of culture and linguist appropriate care. The VA has not committed additional funds to resources to reach out to Native veterans to prevent gaps in the care access and to assist them with reschedule and cancel appointments. Please review our written testimony in more detail of these problems and the policy solutions. I'd like to leave you with the final message. It is imperative that Congress establish a parity between the VAA and the Indian Health Service, equalizing for funds and health IT development. Without parity, the quality of care for the Native veterans will continue to suffer in health outlining. In conclusion, I thank you for holding this important hearing and for inviting National Indian Health Board to testify. We have a long ways to go together to improve care for the Native veterans. We will serve in this way as well. Awa'ata, and that is IAC, for thank you very much for the time spent, and I yield back.
Thank you, Chief Smith. I now recognize Ms. Church for 5 minutes.
Good afternoon, Chairwoman Lee and Brownlee, Ranking Members Banks and Dunn, and distinguished members of the committee. My name is Lindsay Church, and I am the Executive Director of Minority Veterans of America, a nonprofit dedicated to creating belonging and advancing equity for minority veterans. On behalf of our members around the country and world, I thank you for convening this hearing and allowing me to contribute to this discussion on the Department of Veterans Affairs telehealth expansion during and beyond the COVID-19 pandemic. The COVID-19 pandemic has changed nearly every facet of our day-to-day life. The technology that we as a collective society have leveraged in this moment has helped us to preserve the tiny bit of normalcy that we still have and to ensure that we can access basic necessities such as healthcare. VA has worked to rapidly deliver a 21st century telehealth system capable of serving millions of veterans in their charge, but in doing so, made several failed assumptions about veterans' circumstances prior to the pandemic, such as that veterans have stable broadband, a working computer or phone, a private space in which to sit for appointments, and a distraction-free environment. While the transition to this new platform has the potential to revolutionize veteran care, The rapid expansion and implementation has amplified systemic healthcare inequities across the country. These deep inequities have always existed under the surface, but cannot be unseen, nor can they continue. Through telehealth, some have been afforded increased access to mental health services or have been more readily available to connect directly with physicians, while others have been left without the means to access basic care. Comparative to their non-minority peers, socioeconomic barriers exist for minority veterans that undermine some of the foundational requirements to use telehealth services. The VA's telehealth modernization only made healthcare more accessible to those that already had access to technology or the ability to purchase it at the onset of the pandemic. For households that do not have computers, cellular devices, or broadband connection, the ability to attend appointments is a barrier to care. Prior to the pandemic, compared to white veterans of color made on average 13 to 21% less. In addition, Black and African American and Hispanic and Latinx veterans were 8% more likely than their white counterparts to hold sales and service roles, industries which have been among the most greatly impacted by the pandemic. Those struggling from socioeconomic and income inequality prior to the pandemic faced additional threats of unemployment at a disproportionate rate. Marginalized veterans are not able to purchase technology and maintain broadband as a utility to attend healthcare appointments when attaining transportation, shelter, and food are uncertain. VA should provide technology and internet vouchers for low-income veterans to increase accessibility. If VA is currently doing this, we have yet to hear of anyone who has seen this benefit. Availability of broadband networks can present an additional barrier to care. Broadband disparities impact low-income veterans, often veterans of color, and those who live in rural areas, outlying territories, and on tribal lands. Expansion plans must include a racial equity lens to mitigate further disparate outcomes for veterans from specific racial and ethnic groups, to include continuing to work directly with tribal and indigenous leaders on increasing broadband availability on tribal land, as well as providing funding to enact the solutions that people put forward. New barriers also exist for veterans experiencing homelessness who are currently receiving drastically reduced or no care from the VA, as reliable access to the tools necessary to use telehealth can be impossible to maintain. It's disheartening that we barely even mentioned homeless veterans in the plan to serve them in any of this hearing. Based on MVA's current COVID-19 needs assessment, 100% of respondents experiencing homelessness have already experienced barriers to access and care. Expansion of VA telehealth services must include solutions centering veterans experiencing homelessness. As mentioned by Chairwoman Brownlee, COVID-19 has also led to higher instances of domestic violence for women and LGBTQ individuals. For domestic violence survivors, using telehealth without proper security measures can open them to mental, emotional, and physical abuse. Leaving a digital footprint can be deadly for survivors. To ensure the safety of survivors, VA must review telehealth policies and procedures, identify solutions that prioritize patient security, and ensure zero digital footprint options exist. Finally, in the transition to telehealth, minority veterans patients of VA have expressed concerns with issues surrounding the inability to sense rising anxiety over trauma-related topics, misgendering at routine appointments, and overall lack of ability to replicate the in-person clinical experience for patients. Cultural competency on healthcare delivery to minority veterans should be mandatory annual training for providers. Chairwomen Lee and Brownlee, ranking members in Banks and Dunn, and distinguished members of the committees, thank you for the opportunity to testify today.
Thank you, Ms. Church. I now would like to recognize Mr. Bearfield from Disabled American Vets for 5 minutes.
Chairwoman Brownlee, Chairwoman Lee, ranking members Dunn and Banks, and members of the subcommittee. Thank you for inviting DAV to testify on the use of VA telehealth services during the COVID-19 pandemic. As the pandemic reached the United States, it was necessary for the nation to quarantine to slow the virus. By mid-March, the VA was required to make a significant shift in the delivery of health care to its more than 9 million enrolled veterans. VA notified enrolled veterans it will be canceling elective surgeries and temporarily limiting access to its medical facilities while increasing virtual telehealth services to meet veterans' routine medical care needs. Virtual options such as VA Video Connect were already in place and allowed veterans to easily meet with healthcare providers through web-based devices. Another important VA healthcare tool used during the pandemic was My Healthy Vet patient portal. which allowed veterans to send secure messages to their healthcare providers to get prescriptions refilled and have non-urgent healthcare issues addressed. Congress's approval of a $2.2 billion set aside in the CARES Act for increasing VA's IT and telework capacity helped the department move quickly with expanding telehealth capabilities and allowed it to ship out more than 16,000 laptops and 7,500 iPhones to veterans. With targeted funding and outreach, VA saw a near 10-fold increase in VA Video Connect visits. VA was also able to continue providing veterans with critical mental health services during the pandemic. Prior to the shutdown, approximately 85% of mental health encounters were conducted in person, with the remaining 15% provided through virtual options. Once the pandemic began, providers were able to transition 80% of veterans' mental health care visits to video conferencing, telephone, or secure messaging. However, it is likely some veterans struggle to use the new technology, particularly older veterans and those with a severe disability or cognitive impairment. VA needs to ensure assistance is readily available to veterans who need help with the devices provided to access telehealth services. Another critical factor during the pandemic was VA's ability to outreach and communicate with enrolled veterans. Although there was some lag and confusion at first, the VA sent out a series of text messages and updates alerting veterans to critical COVID-19 information, resources, and how to access care. Early on, DAV recommended VA outreach to vulnerable veterans, particularly veterans with serious mental illness, women veterans, those at higher risk of suicide and intimate partner violence, as well as homeless veterans and those who were already struggling to manage with substance use disorders. Moving forward, VA must ensure protocols are in place for case management, care coordination, targeted outreach, and communication for these special veteran populations. As VA begins a phased reopening, it should follow up with veterans who have delayed care to ensure that veterans with complex health conditions are reevaluated in person if necessary. Since there will undoubtedly be a backlog for appointments, VA should utilize community partners to ensure wait times are not excessive. Also, as VA moves forward into a new normal, it should analyze how telehealth has affected healthcare outcomes for veterans, determine veteran preference for virtual services, and assess feasibility of increasing utilization of telehealth services. DAV is pleased that VA has established multiple agreements with large corporations to support its Anywhere to Anywhere Connected Care initiative, which gives rural veterans and veterans without internet service more options to connect with VA healthcare providers through partnerships in their local communities offering video telehealth. In closing, the global pandemic has tested the VA in ways that it could not have imagined. However, given that VA was already a leader in leveraging telehealth technologies, made it the necessary transition to these critical services during the crisis much easier. More importantly, it demonstrated that the VA was able to carry out its primary mission of caring for our nation's veterans despite challenges, and agile enough to deliver quality healthcare services while keeping veterans and employees safer and at a lower risk for contracting the virus. It also provides an opportunity for VA to rethink its care delivery model and possible expansion of these services in the future. Chairwoman Lee, Chairwoman Brownlee, again, thank you for holding this hearing today. This concludes my statement, and I am pleased to answer any questions that you may have.
Thank you, Mr. Bierfield. I now would like to recognize Ms. Bartlett for 5 minutes.
Chairwoman Lee, Ranking Member Banks, Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittees. On behalf of the men and women of the Veterans of Foreign Wars of the United States and its auxiliary, thank you for the opportunity to add recommendation on the expansion and impact of VA's telehealth during the COVID-19 pandemic. At the end of April 2020, the VFW released a survey to determine the experiences of veterans seeking to access VA healthcare, non-VA healthcare, and COVID-19 care since March 13th. The survey also asked for a physical and mental health self-assessment during the past 30 days. Most veterans with scheduled care appointments during the President's declaration of a national emergency reported they used the telephone to facilitate their care, while a third of respondents used My Healthy eVet secured messaging. The VFW urges VA to continue outreach to promote My Healthy eVet's ease of usage and access to secured messaging, prescription refills, and appointment scheduling, and to maintain the highest degree of cybersecurity to ensure users' information is protected. According to our survey data, VA converted many routine care appointments to telehealth, meaning telephonic or video sessions, while non-VA providers were more likely to insist on physical appointments, potentially increasing veterans' exposure to COVID-19. Not all appointments can be conducted via telehealth. Critical essential care appointments such as cancer treatment or dialysis require in-person treatments and pose a substantial risk to the patient if they are delayed or canceled. After March 13th, VA facilities were twice as likely to cancel or delay in-person critical essential appointments than non-VA providers. The vast difference in the handling of these critical essential care appointments raises question on how these appointments can be carried out to create a safe environment for both the veterans and the healthcare professionals during a resurgence of COVID-19, future pandemics, or natural disasters. VFW's survey data also found that almost all veterans expressed no changes with the handling of their medication refills. Furthermore, more than half the veterans were either satisfied or very satisfied with the care they received since March 13th. Therefore, the VFW believes the communication with healthcare providers adequately continued throughout the beginning stages of the pandemic and ensured veterans continued to receive the necessary medication in a timely manner. Veterans have successfully navigated a rapid switch to telehealth. Congress moved VA forward to the using telehealth with the passage of VA Mission Act of 2018, which created an anywhere to anywhere approach that allows veterans to maintain a continuum of care with providers they trust. Telehealth has also overcome long-standing barriers to care. The option of telehealth also eases the fear of sexual harassment or abuse at VA medical centers, eliminating extensive travel and wait times, removing geographic barriers, and lessening the need to arrange childcare. The VFW urges the House to pass H.R. 3228, the VA Mission Telehealth Clarification Act now, which clarifies the statute in the VA Mission Act of 2018, allowing health professional trainees to provide treatment via telehealth under the clinical supervision of a healthcare professional. The VFW continues to work with VA and Philips to leverage the Project Atlas. More than 20 VFW posts have been identified as possible telehealth centers, with plans to deploy 5 VFW Atlas sites in the first phase of the program. The VFW encourages the House to incorporate the parts of S78, this John Scott Hannon bill, into the House companion bill, which would provide the opportunity to expand telehealth capabilities and suicide prevention and mental health programs. The VFW supports VA in its evidence-based telehealth programs by advocating for legislation and outreach. An article in this month's VFW magazine covered research focusing on providing a telehealth brain wellness program to rural vets with anxiety, depression, and PTSD. We asked VA to continue studying evidence-based telehealth complementary alternative modalities. The VFW understands the challenges VA endured since mid-March 2020 because of the COVID-19 pandemic, and VFW membership is pleased and satisfied with the care they received via telehealth during the time of the stay-at-home order. The VFW would like to see telehealth continue to offer and expand as a tool to care for veterans. This concludes my testimony. I thank you for the opportunity to testify, and I'm prepared to answer any questions.
Thank you, Ms. Bartlett. I will now recognize myself for 5 minutes for questions. I'd like to ask this for any panel member. Understandably, the COVID-19 pandemic has changed the way that the VA does business. Veterans' scheduled appointments have had to be rescheduled or canceled. Some have been transitioned to phone calls or telehealth, and people have had difficulty getting new appointments. I'd like to know how the VA has been communicating with your organizations, what tools they've provided you to communicate with veterans, and whether or not you feel that's enough or what more they could do. And I'll open it up to the chief if he wants to comment.
Yes, thank you. This is Chief Bill, and listening to my veteran friends all over the country, I have one friend that's been rescheduled 4 times for a hip replacement. He's an old Vietnam vet. And I had another one in Oklahoma that he just had his leg removed. And it took him in the last 3 months, about 4 times to actually get it scheduled. So those are the deals about getting rescheduled. Even myself, as a Vietnam vet, I'm starting to have problems with my eyes with the diabetic. And I've been, before the pandemic, I was supposed to go up and get a retinal eye scan done because I have a divot in one of my eyes. And they asked me to reschedule, but that's the last I've ever heard from them. So it's a specialty clinic that does it here in Alaska, but that's 300 and some miles away, and that's something that can't be done by telehealth. It has to be an actual visit.
So you're still waiting to get contacted?
Yes.
Okay. Is there any other, thank you, Chief Smith. Is there any other panelists who'd like to comment?
Yes, ma'am. Go ahead, Tim.
Yes, Chairwoman Lee. Are you referring to how VA has reached out to the VSOs?
Yes, I am, and what tools they provided you to reach out to veterans.
Yes, thank you. Our leadership within the VFW has been in contact with VA on their regular telephone conversations. Although we've seen specialty divisions, departments within VA has been lacking in their communication, specifically the Center for Women Veterans. Their monthly partnership breakfast has been canceled pretty much since the beginning of COVID. We are scheduled to have one here in the beginning of July. But that's what we've seen so far as our interaction with VA directly and the VSOs.
Thank you. I think Ms. Church, I heard it wanting to comment.
Yes, Chairwoman, thank you for the question. We hear some of the same sentiments along the wait times and getting rescheduled. Many are getting rescheduled, but it's months away. As an organization, we have heard 0 from the VA.
Thank you for that input. I'm going to follow up. In the testimony, the VA stated that clinics are often the location where veterans hear about services available to them at home. How would you evaluate the VA's outreach and education to veterans regarding services available at home? And I guess I'll start with Mr. Bartlett. I think you may need to unmute.
Sorry about that. Thank you, Chairwoman Lee, for that question. As far as outreach, what we've seen has been minimal. Basically, what we've seen on the VA's website is there. In the last few months, there has been research webinars for VA explaining reproductive health and women veterans and how women veterans can go about their appointments through COVID. Unfortunately, that information was not put on the front page of either the Women Veterans Health website or the Center for Women Veterans Health website.
Thank you. I'm sorry, Mr. Bearfield, would you like to comment on that?
Yes, thank you, Chairwoman Lee. At first, the communication from the VA was very minimal. I can speak personally to it because my wife and I are veterans. And in the beginning, she would receive text messages or emails about the appointments that she had, whereas I didn't receive any information at all. And I had several appointments during that time frame where when I contacted my primary care physician, I was told at that time, yes, the appointment will be canceled or rescheduled. But as the pandemic has pushed on, more information has come, and now we have both received emails or text messages on a more consistent basis from the VA.
Thank you. I yield, and I now recognize Mr. Banks for 5 minutes.
Thank you, Madam Chair. Mr. Bearfield, you made some positive comments about My Healthy Vet in your testimony. Does DAV have a position on what should happen to it?
Thank you for the question. When it comes down to My Healthy Vet, as indicated in my testimony, we see it as a positive, but specifically, I would have to get with the rest of my staff to make sure that we do have a resolution specific to the My Healthy Vet program and our position on that.
Ms. Bartlett, same question. What should happen with My Healthy Vet?
Yes, same thing. At this time, the VFW does not have a resolution on My Healthy Vet, but we're also talking about a program that veterans have used for years. This has been in the VA system for quite a while, and just adding additional components to it, like Blue Button, where then the veteran has access and they can see their medical record or they can see their lab work. They've been around the system for quite a while, and I think it's just something that should continue.
Thank you. Ms. Church, how should VA help, or how should VA best distribute the 50,000 iPads to address telehealth coverage gaps? And also, how should VA expand its partnerships with the telecommunications companies to help low-income veterans bridge the digital divide?
Thank you for the question, Chair. Excuse me, not Chairperson, Congressman. We've seen a lot of programs such as Comcast Internet Essentials, which are available to veterans, but the outreach that we've seen has not been conducive to getting the information in the hands of the folks that need it most. Specifically focusing on communities of color, looking at digital deserts and broadband deserts, and whether or not folks have the access, and focusing specifically on those communities, working with organizations that serve minority veterans specifically, recognizing that we have socioeconomic barriers that don't exist for our non-minority peers. So in our experience, the ability to have broadband as a utility and being able to access at a low cost is a great advantage. But if you don't live in an area where broadband is available or quality, it doesn't really matter. So we have to look at where the digital divide is, where the communities that don't have access to that technology are existing, and really focus heavily on those folks.
Thank you. Mr. Smith, I appreciate your detailed testimony about the Indian Health Services electronic health record and the technology relationship with the VA. Beyond VISTA, what VA systems or platforms does IHS already have access to, and which ones could they get that would have the biggest impact?
Thank you for that question. Alaskan tribes have moved to Cerner and have over 9 years experience and have approximately 200 clinics and hospitals on. The VA should tap into this experience for future discussion. And whatever system we use, a veteran should be able to use his Indian Health Service and have his records, because I have to take my records from the Indian Health Service over to the VA to make sure that they're in when I talk to both my veteran doctor, VA doctor, and my Indian Health Service for my health care with my secondary to Agent Orange exposure as a Vietnam vet. And as a Vietnam vet, an older Vietnam vet, you asked a question earlier about My Healthy Vet, and it's been used for many, many years, and it's not really broken. And when you have a veteran and try to make a change, it's really hard to mess with the veteran once he gets a system that he knows and it works for them. So I use My Healthy Vet, but it's still hard to transfer my information from Indian Health Service to the VA for taking care of my healthcare system. Hope that answers your
Last question for you, That's one more question for you. I'm impressed at how far Indian Health Service stretches its IT dollars. Speaking from my experience in this subcommittee, the VA seems to get better results with targeted IT investments than with massive, ambitious projects. If IHS got the $3 billion it requested for health IT infrastructure, it is quite possible that an EHR implementation could swallow it whole, especially now before VA and DoD work out all the bugs out. However much money is available, could it be more effective to adopt some proven systems that VA has already fielded, increase technology support for the end users, and invest in the networks?
Yes, if we have something that would speak to both Indian Health Service and the VA, it would save us all a lot of money. And
very good. Thank you. My time has expired.
Thank you.
Thank you, Mr. Banks. I now recognize Ms. Brownlee for 5 minutes.
Thank you, Madam Chair. My first question is to Chief Smith. It's good to see you again, Chief Smith. Thanks for being with us today. I just wanted to really ask you how the Valdez tribe is doing during COVID. Have you had a lot of folks infected?
Not at this time, but what we're concerned about is the fishing industry coming up and the cannery workers coming from the lower 48 and the tourism coming into our small town is really concerning. Today, even at our hospital, it was an open day for testing for COVID. My wife went over there, but the time is up and I was at this meeting, so I wasn't able to get tested. So
Can you go to the VA and get tested?
Yes, and I can also go to Indian Health Service, which I have scheduled on the 1st of July to see my Indian Health Service doctor. But like I said before, we're considered rural. It's a 600-mile trip for me to go up to Anchorage and back from Valdez. And that's actually a 2-day trip. Unfortunately, I told the VA one time that it was a suicide run to drive up to Anchorage, get tested, see a doctor, and come back. And the next thing I know is I get a call saying, "Are you okay? Are you healthy? Is there any problems?" Because I used the word suicide. Well, now I've learned to use the term turn and burn because sometimes I do not like to go to the big village, as we call it, because COVID is pretty deal up there. So I'm pretty well isolated in my little community of Valdez. And going to the big city is a threat to me.
So telehealth would really be helpful if it was widely available.
Yes, and I have experienced telehealth but I had to go to the Anchorage VA to experience my first telehealth visit with a doctor in Idaho. But even in that case, they had to have a nurse practitioner running all the machinery, which is, so that you can check you from top your head to your toe. So it's not just the telehealth, the communications, it's all the equipment that you'd actually really need in one of the communities to be able to do a really good telehealth. Because I've seen parts of my body that I've never seen before on a big screen TV.
So do you have you or other veterans within your tribe, do you know of people who are using telehealth for mental health and actually doing that within their homes?
Not that I know of, because with the HIPAA law, they can do it, but we really don't know who's doing it. I know I took a trip up to Glen Allen, and they do have a telehealth room up there where they can talk to mental health people, and it's a secured system. I don't know if my Healthy Vet or whatever would be secure enough for the HIPAA and everything else for mental health issues, but I know it's needed because this COVID-19 has put a lot more isolation on the veterans and the population itself. It's really hard to be hunkered down. Like I said, I was isolated in Vietnam, so I can understand how to be isolated here. But it's really hard to be away from family and friends, and then especially one incident, my son-in-law, his mother is dying of cancer and only has a few more days to probably be in this world. And all of her family from the local way come up there. So when my son and my daughter and my grandkids come back from when she passes, I can't see them for 14 days or whatever till they've been proven because they've been exposed to people that have flown into Alaska to say goodbye to their mother.
Well, I'm sorry to hear that. I thank you. I thank you for being here. I have a lot more questions, but we'll have to wait. And my time is done, and I will yield back.
Thank you.
Thank you.
Thank you. Thank you, Ms. Brownlee. I now recognize Dr. Dunn for 5 minutes.
Thank you very much, Madam Chair. I start with a comment, if I may, to Chief Smith. I think that you're going to see improved connectivity very, very soon. I work closely in another committee with the space program, and there's multiple companies putting satellite constellations up to provide truly broadband connectivity in very remote areas. I understand that most of North America and Canada is going to be turned on later this year by Starlink, which is the service from SpaceX. Verizon is also turning one on in the near future, so I urge you to look at those issues of rural connectivity. I have those, but I'm way down south, so with the same problems in a different location. I want to turn attention to Ms. Bartlett. When the VA canceled the in-person care for conditions that are considered not urgent in mid-March, the VA providers were supposed to proactively contact the veterans on their patient panel to gauge their condition, their interest in switching to telehealth. Do you think that happened based on the survey that of the VFW survey?
Are you specifically speaking about routine care or critical essential care appointments?
So I was thinking the care, they had appointments in the VA medical centers and they were canceled and they were supposed to have been offered telehealth. Do you think that happened?
So what we saw in our survey, we had just asked how those appointments were changed. Unfortunately, we did not follow up to see if and when those appointments actually did take place.
Okay. This is change Mr. Barfield for a moment. You made a comment that you said the VA must be mindful that telehealth may not supplant face-to-face visits or treatments. You're absolutely right in some cases, and we should identify opportunities to expand the use of telehealth without harming patient care outcomes. In what way can you elaborate from the patient side of this? I'm a physician. I know my side. From the patient side, what do you think is different in the outcomes face-to-face versus telehealth, and in what circumstances?
Thank you for the question. Yes, telehealth has come a long way, and this pandemic has shown what the capabilities of telehealth can be. But for some veterans, they still feel comfortable with going to see their primary care physician or seeing a specialist face-to-face to discuss their condition. So in my statement, I indicated that yes, telehealth should be expanded, but in certain circumstances and depending upon the particular veteran that is being taken care of, some veterans still feel comfortable sitting right across from their physician when it comes down to discussing their matters. So that aspect of veteran healthcare cannot be taken away.
So I agree with you. I feel that seeing my patients actually assists me in making a better assessment and understanding what their choices are as well. So I think we're completely simpatico on that. An interesting area, not my area especially, but an interesting area here is the mental health telehealth. Certainly, telemental health is better than no mental health care, but it seems that that's a particularly an area that we've gotten a lot of complaints about. Shifting to telehealth actually seems to leave this patient population high and dry. Do you have an opinion on that?
My personal opinion is that telemental health services, as I mentioned in my oral statement, the VA was able to shift relatively quickly to getting 80% of telemental health services switched over to either video or telephone to make sure that veterans that needed the assistance or needed the help had an outlet in order to turn. And they should expand that particular portion of the program to make sure that as veterans who are in need of mental health services have a way to get them, whether it's via telemental health, telephone calls, or being able to go out into the community to get that care if necessary or needed.
I thank you very much for your comments. And Madam Chair, I yield back.
Thank you, Dr. Dunn. I now recognize Mr. Lamb for 5 minutes.
Thank you, Madam Chair. I just wanted to ask any of the panelists, a couple of you mentioned aspects of it in your testimony about the distribution of iPads, laptops, and phones to veterans in need to use for telehealth. Do you know anything about how the VA chose to distribute those, to who, on what basis, and do you have any guidance for us with future spending that we do or support for those programs as we expand it and make it accessible to more veterans, as to how we can make sure we access the veterans that are most in need?
This is Chief Bill from Alaska, and I, as a veteran, knew nothing about any support like iPads or anything else for communication. We were, as a veteran and as a tribal veterans representative, our resources are things like 907 Vets, connecting vets through social media of things that come up and what we need to do to take care of our brothers and sisters, veterans. You know, when they talk about the iPads and stuff, the VA should look at incorporate mid-level providers such as community health aides, behavioral health aides, and dental health aides in their telehealth service too. But being able to get the equipment to the veterans in the rural areas, just like you said, they're thinking about setting satellites up, but not all areas of the United States or Alaska is covered with web to be able to use the internet.
I apologize that they missed you, Chief, and we will try to push them to do a better job next time. Lindsay, did you get any feedback from your members on how well, if at all, the distribution was working?
Yes, sir. First and foremost, this is only actually the second time that I've even heard about technology being issued by the VA. So if this is happening, which I'm assuming it is, we're not hearing about it. People on the ground are not hearing about it. So outreach has to change in whatever way makes sense for the communities that need to be served most. In our experience, based on survey data, what we've seen so far is the people that need technology and access, low-income folks, people that make less than 80% AMI, folks that are homeless, holding technology and having access to that technology is really difficult when you're holding all of your belongings on your back. So I think it's really important that the VA figures out a tailored strategy for serving homeless veterans or veterans experiencing homelessness. And the last is communities of color. We already know that there are disparate outcomes in specific neighborhoods and specific areas of our country. We need to focus heavily on outreach in those communities, whether it be through veterans or non-veterans. That's the thing, is that we often focus so heavily on outreach to VSOs that we forget that there are organizations that serve veterans in the communities that we want to be in, that we can create lasting connections with and actually serve veterans through those means as well. So we have to get unique with these strategies. We have to think outside the box and start with a nuanced approach to what we're doing and work from the outside in.
That's very well said. Thank you. Did anybody else? I have about a minute and a half left. Did any of the other witnesses want to jump in on that?
Representative Lamb, this is Tammy Bartlett. I just wanted to quick add, I believe it was in mid-April that the VA put out an announcement about their partnership with Facebook and the American Red Cross for about 7,400 iPads that were be given out. And that was to basically bridge the gap of isolation. Veterans who were eligible for that program had to be enrolled in the VA and or a geriatric or extended care program with a caregiver.
Thank you for that, Ms. Bartlett. I really appreciate it. Thank you to all the witnesses for being part of this. And, you know, the VA was moving very quickly as this pandemic developed, and I think they did a lot of things right. This is probably one where we can really redouble our efforts to target people that are most in need. So thank you all for participating. Madam Chair, I yield back.
Thank you, Mr. Lamb. I now recognize Mr. Watkins for 5 minutes.
Thank you, Madam Chair. Ms. Bartlett, I want to thank VFW for conducting the surveys on how veterans access VA services. The results are very informative, especially when we read them alongside VA surveys. Your survey found about half of veterans still call VA on the phone to schedule appointments and facilitate care. And about 1/3 use My Healthy Vet patient portal, including myself. What improvements to the phone system and the call centers would you feel is most beneficial, and what new features do your members want to see in My Healthy Vet?
I feel improvements that can be done to the call center would be around having those individuals available to be on those phones to connect to those veterans. I myself also use My Healthy Vet often through these last few months. For example, I had some heart palpitations. I reached out to my primary provider. We got on the phone call. Next thing I know, I had a blood pressure cuff coming to my home here in Pennsylvania, as I'm a caregiver now for my parents during the pandemic. And I was able to put that blood pressure cuff into my Telemove module that I have to do my weight management through Telemove. We found in the study, and I do want to add because we also often mention our elderly veterans not being able to make that connection with technology, and the age group of the over 60 and over were 51% telephone, and still 31% use the My Healthy Vet. And I think that also has to go to the longevity of My Healthy Vet. It's been around, people understand how to use it, and they can grasp that technology.
Right, I agree. Thank you. And you noted that 20 VFW posts were considered as potential locations for Project Atlas. Now, what are the criteria to select a post? How long does it take to get the telehealth equipment up and running? And is my post, Topeka Post VFW 1650, one of the ones considered?
I will have to get back to you for the record on the criteria of becoming a Project Atlas telehealth site. Although I do want to mention Eureka, Montana is one of the first up and running. And one of the criteria there is because their mental health capabilities in their clinic is so far away from the veterans in that area.
Makes sense. Mr. Bearfield, I'm concerned about backlog of appointments that were deferred during the last few months. But before all those consults and procedures can be carried out, there seems to be a big administrative backlog to schedule them. How can we use technology to smooth out all the scheduling that needs to happen?
Thank you for your question. With as vast as the VA medical system is, there should be a protocol in place to where those appointments that have been made should be tracked, and a system should be put in place where those veterans can be contacted to reschedule those appointments in a more timely manner. But also, there should be a way where if those appointments are pushed out beyond a particular time frame, then that's when the ability to use community partners should come into play and help fill the gaps where the VA might fall just a little bit short.
Understood. Thank you. I'd like to thank the whole panel. I appreciate your time and your expertise. And Madam Chair, I yield the balance of my time.
Thank you, Mr. Watkins. We have a couple rounds of additional questions, and I'd like to start with Ms. Bartlett with VFW. Understanding that this Atlas pilot project went live at the site in Eureka, Montana. And can you give us a sense of that experience and whether or not the VFW has done any satisfaction measurement of that pilot so far? I know it was just a small number of patients who were served. I think it was about 11, but has there been any, post satisfaction survey, and can you give us a sense of that?
Thank you, Chairwoman Lee. At this moment, I am not aware of any measurements or outcomes that have come from those few veterans who had already used that facility pod. But that is something I can definitely look forward into and reporting it back to your office.
Okay, thank you. And do you have a sense of whether veterans want to have this type of access?
Having the Project Atlas sites gives a sense of security and privacy, especially if you're a veteran dealing with IPV at home. It's something that, you could somehow find an excuse to leave the house and still have privacy to continue your telehealth appointment if you're unable to have it in your home, or maybe distracted by children or pets within your house to get away to have that quiet time and speak directly with your provider.
I think we all, having been on many Zoom calls, can understand that. My dog seems to want to bark as soon as I start speaking. So in terms of, are there any, do you have any recommendations or any limitations or issues with expansion of that you'd like to make us aware of?
A recommendation I would have is to look into that grant portion of the S785, the John Scott Hannon bill, sorry, and ensuring that gets into the House Companion Bill. That will give organizations such as Philips and with the partnership with VA, VFW, and other VSOs the opportunity to fund those kind of telehealth pod sites.
Great, thank you. I am finished. I now yield, and I'll recognize Ms. Brownlee for 5 minutes.
Thank you, Madam Chair. Ms. Church, I had a question for you. In your testimony and opening remarks, you touched on a topic which my subcommittee has been especially focused, and that's health inequities. So, in this discussion of telehealth, the expansion of telehealth with, due to the pandemic, do you think VA's telehealth efforts can address the access problems that are disproportionately affecting minority veterans and even veterans who are homeless? Do you actually think it can help?
Thank you for the question, ma'am. I absolutely do believe that the VA can do better and that there's a great amount of opportunity here. Just by creating a culture of positive, welcoming environments for minority veterans and working on those margins and those folks that are furthest pushed to the margins, we really have an ability, I often hear the phrase, that when we create access for one, we create access for all. When we look at the margins and we create access for folks in broadband deserts, we create access for more folks as we do that, and in being able to create care for everyone. So yes, I do absolutely believe that the VA can do this. I think that undertaking and doing this with an inclusive mindset, rather than just saying we want to go and get the most diverse client set, we need to actually analyze the internal culture, assess what's happening at the VA and why it's so toxic for minorities, and why historically for years and decades, minorities have been complaining about VA care. So yes, I absolutely do believe that in both telehealth and in care at all, VA has a huge way to go, and they can lead the charge in this inclusive wave. So I absolutely am a big believer that VA has the potential to really do this and set the pace for the rest of the country to do so as well.
Great. And Ms. Bartley, do you agree? I was, when you mentioned in your testimony that the Center for Women Veterans, their meetings had been canceled through this, COVID time. And that's a concern to me, because I think we need more access than less, and the VA needs to be hearing more from veterans about how they can improve. And so that's obviously a concern. I'm glad to hear that they're going to have meeting coming up. But do you have any other comments on in terms of improving access for those who are disproportionately impacted?
I just wanted to quick mention, Chairwoman Brownlee, that as we hold this hearing right now, the VA is having a Women Veterans Facebook Live event. So unfortunately, some will have to rewatch it. And also, the Center for Women Veterans over the last year or two has started implementing a way of communicating through their monthly breakfasts. So, which sort of dumbfounded some of us when they discontinued having the breakfast meetings, because some of us, before COVID, who were able to actually sit in the room, were able to hear from other women veterans and organizations that support women veterans from all over the nation.
Thank you so much. And I have another minute or so. So, Chief Smith, I wanted to go back to you. I know that the last time we were together, we had good conversations about the 2010 MOU and the upcoming new MOU that is going to be negotiated. And I know in the 2010 MOU, one of the elements of that was that telehealth was going to improve healthcare delivery in Indian country. I don't think that that's actually happened, but my question to you is: have you been in contact at all? Has the VA reached out to you at all with regards to this upcoming MOU, its drafting, and any revisions that they might be making? Has your organization been involved?
Thank you for the question. No, we really haven't been involved much. We are trying to start a new veterans committee so we can get some input in there. But when we talk about telehealth, I'd like to put in a word for the TVRs, the Tribal Veterans Representatives, because that's how, when Susan Yeager was up here in the VA, that as I was getting the TVR training, I was able to learn about how to get into My Healthy Vet and everything else. And as you know, Alaska has over 70,000 veterans, and only half of them are registered. So rural health, TVRs are very important to be able to drag our veterans back out of the bush, because a lot of my brothers that come back from Vietnam, because of the reception, they never went to the VA. But now they're getting to the ages where we're dying off very quickly. And it's time for the children, the aunties, and the nephews to drag my Vietnam brothers back to the table so they can get the health care that's desirable and needed for them as we age. I myself is in that same stage. But the TVRs are a very important role in that, and they able to help the veterans. And there's, like I say, there's groups like 907 Vets that are out there. That's how veterans help veterans.
Yeah.
The VA is one thing, but it takes a veteran to talk to a veteran to tell them, come on back to the table. This is not the same VA we did when we come home in the 70s. This is a way to remove some of the spit and some of the deals from us and get the health service that you need before you cross over and meet the rest of our family.
Thank you for that, Chief. Thanks very much. I yield back.
Thank you. I'd like to thank all the witnesses for being here today and participating, especially at this critically important time as we continue to examine these issues and also look at this not just as a crisis, but also an opportunity on how we can move forward with telehealth and continue to expand access and satisfaction for our veterans. Ensuring that access to care is met even during a time of a pandemic is obviously the responsibility of the VA and this body. And I commend the VA for the progress that you have made, as we've heard, but there are, and thanks to the panelists on the second panel, certainly some critical gaps remain, and we can always make improvements to make sure we're expanding access and satisfaction. We cannot assume that because there are more connections or more devices that all veterans' needs have been met. I hope we can all continue to work together on these critical issues, both with the VA and the organizations that we've heard from today and others whose voices that we have not yet heard. I now also would like to recognize the chair of the Health Committee, Chairwoman Brownlee, for her closing remarks.
Thank you, Madam Chair, and I too want to join you in thanking everyone for being here today. I think certainly from our first panel, it's clear from today's discussion that while VA was able to really pivot quite well to telehealth with a lot of success, there's also been some challenges, particularly in reaching some of our most vulnerable veteran populations that will really require ongoing creativity, commitment, and resources. And I'm very grateful to our non-governmental participants who joined us today and shared the perspective of your veteran members. And I just urge you to stay in close touch with me and my staff so that we can take your recommendations into account as we continue our legislative and oversight responsibilities excuse me. And I'll just end with saying that I really do commend the VA for truly being a pioneer of telehealth in our country. I'm sure one of the outcomes of this pandemic will be extensive expansion of telehealth, both within the VA and outside in non-VA healthcare delivery. But what I challenge the VA in is to also to be a pioneer in closing the racial and income divide through their telehealth delivery system. And I think that is an area that we still need to have a very sharp focus in, because I think we have heard from many here that telehealth, if we can bring telehealth to those who have been most disadvantaged, to our homeless veterans, to Indian country, I think we could really, really improve our services like we have never done before. So again, I thank everybody for their input. It's been a valuable meeting, quite worthwhile, and I yield back. Thank you very much.
Thank you. All members have 5 legislative days to revise and extend their remarks and include any extraneous material. This hearing is now adjourned.
Thank you. Have a good day.
Yeah, thank you.
Thank you, everyone.